Welcome back, focused learners. Today, on The Explainer, we're diving into something absolutely crucial in modern dentistry, the types of surgical guides for dental implants. Our goal today is pretty straightforward, but honestly, it's a real game changer. We're going to demystify this complex taxonomy of surgical guides and turn it into a clinical framework you can actually use right away. We're moving past the old guesswork of freehand placement to see exactly how specific anatomical situations demand very specific guided solutions.
Okay, let's dive into this and look at our roadmap. 1. Guided surgery foundations. 2. Classifying by support method. 3. Drilling protocols explained. 4. Navigating case complexity. 5. Specialized advanced guides. And finally, making the right choice.
Starting off with Section 1, Guided Surgery Foundations.
The stakes in modern guided implant surgery are incredibly high. Human anatomy varies drastically from person to person, so a one-size-fits-all approach, that simply doesn't work. As the source material perfectly puts it, choosing the wrong type of surgical guide can turn a routine implant case into a challenging procedure with compromised accuracy. So your selection literally is the defining difference between a smooth, predictable procedure and one that is highly stressful and reactive.
To make sense of all the options out there today, we need a reliable system. Think of this as your bird's-eye view of the three main pillars of guide classification. First, we categorize by support method, which determines your stability and seating accuracy. Then, by drilling protocol, which dictates how much of the actual cutting you control. And finally, case complexity, which drives the design and manufacturing requirements. Understanding how these three pillars work together is, frankly, the ultimate solution for predictable success.
Let's move to Section 2 and see how this builds. Classifying by support method. This first pillar is all about the anatomical foundation of stability. Basically, what exactly is bearing the weight and holding that guide securely in place? Anatomically, we're looking at three primary structures here: tooth-supported, mucosa-supported, and bone-supported. Let's break down their distinct advantages and limitations. First up, we have tooth-supported guides. Picture this like a precision-fitted retainer that just snaps securely over natural teeth. Because it relies on multiple contact points across those rigid teeth, it virtually eliminates any movement or rocking during drilling. This is absolutely the gold standard for partially edentulous cases. In fact, the data shows these guides achieve the highest accuracy across the board, with mean deviations often sitting nicely below 1 millimeter at the implant apex. It's really hard to beat that kind of precision.
But what if the patient just doesn't have enough remaining teeth? Well, that's where mucus-supported guides step in. These rest directly on the soft gum tissue for fully edentulous arches. Now, you do have to exercise some caution here. Because soft tissue can compress under drilling pressure, you can sometimes introduce minor deviations from your planned path. So, to maximize stability and fight off that compression, you need a really careful design with maximum tissue coverage and very often stabilization pins that anchor right through the tissue to keep the whole shebang locked down tight.
And this brilliantly illustrates the extreme ends of our spectrum. Over on one side, you've got the tooth-supported guide. Highly stable, beautifully non-invasive, but obviously it requires adequate dentition. On the flip side, you have the bone-supported guide. Now this offers unmatched rigidity because it rests directly on the jawbone, which completely eliminates that soft tissue compression we just talked about. But the catch? That rigidity requires a highly invasive surgical flap to expose the bone, which bumps up surgery time and post-operative discomfort. It's just a necessary trade-off when you're tackling those complex full-arch cases. All right, Section 3, Drilling Protocols Explained.
We're shifting gears now from how the guide is held to how much of the actual procedure it controls. Take a look at this measurement, 2 to 2.5 millimeters. To put that into perspective, that's roughly the width of a single piece of dry spaghetti. That is the exact diameter of a standard pilot drill hole. Pilot guides only control this initial entry point. Once you've got that established, the guide comes out and the rest of the drilling is done entirely freehand.
So the key takeaway here is knowing exactly when to use which protocol. Pilot guides give you that controlled initial entry, but with high tactile flexibility. They're fantastic for experienced surgeons who really want to physically feel the bone density as they go. Fully guided systems, on the other hand, offer complete start-to-finish control, from the pilot drill all the way to the final osteotomy prep. Basically, every drill size has a corresponding sleeve, which prevents deviation at every single stage and makes absolutely sure the final placement matches your virtual plan.
Moving right along to Section 4, Navigating Case Complexity.
Guide design scales up significantly in difficulty depending on the scope of the treatment. Think of it like a complexity ladder with 3 steps. Step 1, single implant guides. These are straightforward, easy to make, and honestly, the perfect starting point for clinicians. Step 2. Multi-unit guides. Here you have to plan multiple trajectories that work together and ensure the whole thing stays stable even as drilling creates more holes in the bone. And then step 3. Full arch guides. This is maximum complexity. The stuff you use in all-on-4 or all-on-6 protocols. It makes perfect sense that you want to master single-unit cases before jumping into the extreme precision required for full arches, where even a tiny error is magnified across multiple implants.
Next up, Section 5, Specialized Advanced Guides.
Now, what's really interesting about this slide is how we move beyond standard protocols into highly engineered guides built for multi-stage clinical needs. An incredibly ingenious example is stackable guides. Instead of just one guide, this is a whole sequence used during a complex procedure. So the first guide might direct your bone contouring, and then a second guide literally stacks right onto that newly modified anatomy to direct the actual implant drilling. It's just a super smart way to manage complex full arch modifications step by step.
And speaking of bone modification, let's talk about bone reduction guides. These are specialized templates directing controlled osteoplasty. They incorporate cutting guides or depth stops that show you exactly where and exactly how much bone to remove, so you can create this ideal flattened recipient site. By definitively stopping you from over-reducing, these guides are absolutely critical for ensuring the implant is stable later on and, most importantly, safely protecting the patient's nerves.
Then we have immediate placement guides. As the name suggests, these direct precise implant placement directly into fresh extraction sockets. Now, the unique design challenge you run into here is that the guide has to intelligently account for the void left by the pulled tooth, all while still hitting perfectly accurate positioning in the remaining socket anatomy. Often the guide actually incorporates the tooth being extracted into the support structure itself right before removal. Pretty clever, right?
Let's wrap things up with Section 6, Making the Right Choice.
So, what does this all mean? We've explored the anatomy, the drilling protocols, and the complexity scales, but now we need to answer this crucial question from our source material. How do I know when to use a pilot guide versus a fully guided system? Well, framing this final decision correctly really comes down to evaluating two things: the patient's specific anatomy and your own surgical goals.
Here is the final clinical framework for you to take away and use. First, evaluate anatomy. Do you have strong remaining teeth for support, or are you working with an edentulous ridge that's going to need mucosa or bone support? Second, assess complexity. And definitely make a mental note of this. Cases anywhere near anatomical danger zones, like nerves or sinuses, always, without exception, demand the maximum accuracy of fully guided systems. Finally, consider resources. You have to honestly factor in both the surgeon's experience level and your lab's capacity to actually manufacture these complex tools. So we'll end with a final provocative thought for you to ponder. Are you ready to integrate advanced surgical guide technology to elevate your next implant case? Honestly, understanding these classifications takes the anxiety and the guesswork completely out of the process. When you match the right guide to the right clinical situation, you are paving the way for predictable, efficient, and truly exceptional success. Thank you so much for joining me on this explainer. Keep learning, keep pushing your practice forward, and I'll catch you next time.